start with the first cranial nerve, and that's the olfactory nerve. And it deals with the sense of smell. So you usually don't have to test it because it's quite hard to get the equipment that you need. But you ask the patient, you say, okay, Donica, have you noticed any change in your sense of smell?
No.
Now, you don't say, do you have a smell or do you have any new smells? You know, people can misconstrue these things. So it's a change in your sense of smell. Now, loss of sense of smell is called anosmia. And we all have experienced it at some point, i.e. we've had a cold or a flu. Sometimes it's nasal polyps because the nerve goes up, not surprisingly, from your nose. And it goes through the cribriform plate of your ethmoid bone, and then it goes under the frontal lobe to the olfactory bulb. So lesions of the first cranial nerve will be in the nose, at the cribriform plate of the ethmoid bone, such as the base of skull fracture, or at the base of the skull. So a tumour, for example, at the base of the skull would cause anosmia if it had been growing there long enough, usually a meningioma. And then in neurodegenerative conditions such as Parkinson's, it can be an early sign of Parkinson's, can be anosmia. Now, if someone says, on the other hand, that they do have a problem with their sense of smell, well, then you must test it more formally. Now, to do so, you don't want to stimulate lacrimation or gustation, so nothing too strong in terms of odours that you'd use. Generally, it's recommended bland but distinctive odours such as coffee or mint. So, I'm going to explain to you that I'm going to put a specific smell under one nostril while including the other. So if I ask you to close your eyes, I'm going to include one nostril, and I want you to tell me what you think that is. Okay, can you smell that?
Yeah.
And what is it?
Coffee.
Okay. I'll do the other one. Now, right, I'm going to include your nostril again. Now, could you take a smell of that, please?
Mint.
Mint. Mint and coffee are the two that are usually recommended to establish whether or not there is a loss of sense of smell or anosmia. We're now going to examine the second cranial nerve, or the optic nerve. As you'd expect, the optic nerve is all to do with vision, but it's, in my view, one of the most complicated cranial nerves to examine because there's so many facets to it. What you do in the first instance, however, is examine what you think you're going to examine. That is visual acuity. And you want to see, can someone see in the distance, can someone see up close, and can someone see colour? So far, near, and colour vision are what we start with. Now, the first thing you must ask the first question you must ask of a patient is, do they wear glasses and what for? So, do you wear glasses?
I do.
And what for?
I'm short-sighted.
Short-sighted, okay. So you use it mainly for far vision or for reading?
For far vision.
Far vision, okay. So when testing person's vision, you give them all the chances possible. So if you wouldn't mind putting on your glasses there, Donica, that'd be great. The first thing we're going to do is test far vision with a Snellen chart. Now, the Snellen chart is held at 6 meters away from the patient at the same level as the patient. And you test one eye at a time, and you test corrected vision, i.e. with glasses on, but you can also do it with uncorrected vision, i.e. with glasses off. If someone has contacts, complicates it in the setting of an outpatient, but ultimately leave them on. So I'd ask you if you wouldn't mind covering your right eye first. Thanks, Donica. And you start at the top line and work your way down to the line, the lowest line that you can see, if at all possible. So if you could just read some of the letters there.
H, Z, C, O, R, O, K, D, H, N, Z, O, N, K, C, R, H, S, V, D, D, S, O, or Z.
That's great. So at 6 meters, Donica can read size 6 on the Snellen chart, so he's got 6-6 vision. In other words, that's what used to be called 20/20 or perfect vision, corrected. If Donica could not see at 6 meters any of the lines of the Snellen chart, I move the Snellen chart to 3 meters, covering one eye again. You then see which line he can read, and at this stage it's no longer 6/6, it's now 6/3 vision, and so on. If then he can't see any of the lines at all, no matter how close I get to him, then I try and discern whether he can see hand movements in one eye, and if that doesn't work, whether he can see light. So that, as you can see, we're going from normal vision to poor vision to clinical blindness. And you do this for each eye in turn, and you do it for corrected and uncorrected vision. Now, clearly you'll do it much more quickly in the examination setting, so just do it with glasses on if possible. Quite frequently, one will find in the outpatient setting that the patient has forgotten their glasses. Not a disaster, but you do still need to test visual acuity. In this case, you use a pinhole, and I've mocked one up here, albeit a little crassly, and just made a pinhole in a small piece of paper. Now this will try and overcome the refractive error in the affected lens. So in this situation, I ask the patient to cover their left eye and hold the piece of paper if they will. Can you hold that on? And look through the pinhole towards the Snellen chart. So this is just used in the absence of glasses. So it's kind of a made-up glasses, if you like. And hopefully that'll correct the refractive error if there is one, and enable us to enable the patient to see better from in far distance. Thank you. The next part of the second nerve is near vision. So in near vision, we're really just testing how someone can read. And again, this is fairly simple. We tend to use Jaeger plates, Jaeger plates. They're not readily available, it has to be said. So what we tend to do really in clinical terms is just get someone to read normal newspaper type print with their glasses on and one eye after another. The next part of the visual acuity aspect of the second cranial nerve examination is colour vision. And it's very important to test this particularly in people who've had previous optic neuritis, because they tend to lose red coloration quite early on. Now, people may report a loss of colour vision to you, and they might indeed give a family history of this, but you must test it formally with these Isahara plates. Now, they're available throughout the world, obviously, and they're very standardised. So as you can see, the plates have a test plate with a number in the middle. So the test plate is usually 12, and you shouldn't, unless one is unable to see at all, you should be able to call this. It doesn't affect colour vision. So I'd give them to Donica, if you don't mind holding those, and I'd ask you to cover one eye. Cover the right eye, we'll always start with. I'll flick through them for you. So as you can see, can you call out the number you see there?
12.
And then slowly we'll go.
8. 29.
So that's 3 out of 3.
5. 3.
5 out of 5.
15 and 74.
7 out of 7.
6. 45.
9 out of 9.
5. 7.
11 out of 11. Sorry.
16 and 73.
13 out of 13. And then we're back to the test plate, hence the quizzical look on Donica's face. So that's the test plate to say the test is ended. So there can be 13 plates in some of the Isahara books or 17 in others. But in essence, you've got perfectly normal colour vision in your left eye, and then you repeat the test for the other eye. And you mark that down then as corrected and uncorrected once more. The next part of the optic nerve examination involves visual fields. And this gives us an overview of what the patient sees, both centrally and peripherally. Now, a gross overview of visual fields when testing is usually quite helpful. So what I tend to do in the clinical situation, to speed things up a little bit, is ask the patient to focus directly on my chin, and I'm going to hold my fingers up here. I'm going to move one finger at a time, or both together indeed, and I want you to only point to the finger I move. So which finger, can you point to the finger I move? Okay. Thank you. Okay. Perfect. So that'll give me a gross idea of what's going on. However, if I suspect that there might be a visual field defect, I need to go into it in a bit more detail. So I'd ask you to gently cover your right eye, focus on the tip of my nose, and I'm covering my left eye, and we're a metre apart. So a metre apart, I will bring my finger in and say, can you tell me the moment you see my finger moving? Now, and from 4 quadrants, and still with my eye closed, and then up again. Now, can you swap over to the other eye, please? I close my right eye this time. Tell me when you can see it. Keep looking at my nose. Can you see it moving?
I can see it. I can see it. I can see it. I can see it.
Great. So thank you very much. So there's a full range of visual fields on the periphery. Now, the next thing you need to do is measure central visual field. And often, say for instance in MS, people get optic neuritis and develop a central scotoma. It's not the only reason, of course, but it's one of the more common ones in clinical practice. So to examine central vision, you use a red-topped hat pin. This is to look at the central visual field. Remember that we all have a blind spot. When you're driving, you know that you have a blind spot, and that's where all your optic nerves, where all your nerves are coming into the optic nerve. So as a result, if you get any damage to that area there, you lose vision centrally. As a result of that, the first colour to go tends to be red, so hence the red-topped hat pin. So you ask the patient to cover their right eye, if they will. This can be quite tricky. I'm not very good at it most of the time, to be honest with you. I'm covering my left eye, and I put the pen up in front of Donick and I say, this is a red-topped hat pin. Can you see it? And can you see the colour? Okay. Now, if you keep looking at the tip of my nose, I'm going to bring this in from your left-hand side, and at some point I will try and identify your blind spot. So by which I mean, tell me when the top of the pin disappears. Now, okay, so I'm now in, so to speak, his blind spot, and now I need to map it out. So I'm going to move it, and I want you to tell me when the red-topped hat pin reappears. Disappears? Reappears? Disappears? Reappears? Disappears? Reappears. Okay, so it's a normal sized blind spot, but if Donick had previous optic neuritis, you'd find that you could get quite a large blind spot there, and it gives us an idea of the underlying pathologies. We're heading in towards the optic nerve. The next part of the second cranial nerve examination is examination of the light and accommodation reflex. As you know from childhood, when you're exposed to bright light, your pupils will become smaller. In the dark, for that reason, when your pupils will become a little bit bigger. So what we do in clinical practice is examine the light reflex with a strong light. Now, we usually dim the lights quite dramatically to allow for this to happen. Now, because the light can transfer from one eye to the other, we often ask the patient to put their hand like that up in between the two eyes. Now, as an overview, what's going to happen here is I'm going to shine a light in Donick's left eye. Now, the mechanism from there is the optic nerve will register this. It will transmit this information back to the pretectal nucleus of the midbrain, which will feed into the Edinger-Westphal nucleus, which will then tell the third nerve to come back to bring the parasympathetic supply back to the eye and say, make the pupil smaller. So, in simplistic way, it says, there's light in my eye, tell the brain, come back and shut down. Now, what happens is it's a consensual reflex. So as I shine the light in this eye, the other eye will simultaneously constrict. So I shine a light, and you shine a very bright light, preferably in the dark, in one eye, it will constrict, and you then check, and the other one constricts. That's great, thank you. The importance of this is that you also use, when you have the light in your hand and you're doing this, you look for a relative afferent pupillary defect. If someone has had optic neuritis in the past, the insulation, if you like, around that eye, around that optic nerve, has been damaged. So while it'll transmit the signals that are along it, it'll transmit so not as well as it used to. So in other words here, if I've already found a central scotoma, and I swing the light into this eye, it'll constrict in response to the direct light response, and the other eye will constrict in response to the consensual light reflex. However, to perform the swinging light test, I'll swing the light from one eye to the other, as one would imagine one would. So, just to explain this, I'll have constriction left eye, constriction right eye. Now, as I'm swinging the light over, dilation, dilation. Constriction, constriction, dilation, dilation. Constriction, constriction, dilation, dilation. Now, at some point in this, the badly affected nerve, the afferent nerve that's been affected, will say, it'll say, I give up, I can't take all this light. And you'll get a situation where you're putting a direct light on that nerve, on that eye, and the eye will be conversely dilating. And that's called relative to the other eye, afferent, the problem's going in, pupillary defect. And it's often seen in someone who's had a previous optic neuritis. The next part of the second cranial nerve examination is accommodation, the other reflex. A little less well understood, but it works through the optic nerve, relaying signals to the visual cortex, and then feeding back to the pretectal nucleus and into the eye via the parasympathetics once more. Again, throughout your examination, I'll repeat myself a lot, unfortunately, but the fact is you must communicate to the patient to make sure that they understand what you're doing. So you must be very clear and say, Donick, I want you to look specifically at the top of that cabinet over there. I'm looking at your far vision now, and then I'm going to ask you to focus on a near object here. And now look away, and now look close. So what happens is one's eyes tend to constrict from looking from far to near. An easier way of doing the accommodation reflexes, doing them all together, is, if people don't mind, I'm going to ask you to make you go almost cross-eyed if you like. So as I move my finger in from afar, his eyes will converge and his pupils will get smaller. So follow right in, go cross-eyed. That's perfect. Well done. Not easy, I accept that, but you did very well. So they're the accommodation reflexes and the light reflexes. And disturbances of these are really good red flags, if you like, of eye disease. The clinical pointers here are crucial. Oftentimes we will be presented with someone who has just developed a large pupil or indeed a small pupil. So you say, well, for example, if Donica has a single large pupil and he comes to a neurologist and says, oh, I woke up this morning, my pupil is large. You have to look at, well, is it just in isolation or is it due to other causes? The first thing you always think of are drugs. So a large pupil is illicit drugs such as cocaine or eye drops that used for dilating the eye can cause it. The other thing you think of is a third nerve palsy, but in which case you'll have other features, as we'll see on the rest of this video. But there's no evidence of ptosis, and the pupil, the eye is in the normal position. And then the fourth cause is Holmes 80 pupil, in which case it's a pupil that reacts very sluggishly to light, and it might be a Holmes 80 syndrome in which the reflexes are reduced. So drugs, third nerve and causes thereof, and a Holmes 80 pupil will be the common causes of a dilated pupil. If, on the other hand, a small pupil is seen, then you say, again, it's drugs. Is it opiates? Is the person taking opiates for some reason? And if it's not that, you think of a Horner syndrome, in which you have ptosis, meiosis or small pupil, anhidrosis and enophthalmos, and then you have the causes of Horner syndrome. Or is it due to syphilis, Argyll-Robertson pupil in particular? So therefore you see the importance of this and the reactions of accommodation and light to the clinical setting. I think a lot of students find the ophthalmoscope particularly daunting. I certainly know I did for many years. But if you keep it nice and simple and try and understand it in the very basic terms, I think you'll be able to get a handle on it earlier than I did. The first thing you have to do is learn how to turn it on. So they vary, and they'll vary from hospital to hospital, but at least acquaint yourself with the ophthalmoscope. The second thing is, once you've learned how to turn it on, which isn't rocket science, you then set the diopters to 0. You put your index finger on the dial, and you hold it up, and first check that you know what you're doing by looking at your own hand. And once you can see your own hand, at least you know where you are in space, if you like. Now, then you bring the patient and say, I want you to darken the room, and you ask the patient to focus on a specific point in the distance if they don't mind. Now, if you know the pupils are very small, you may have to dilate them, but that's not usually practicable in the clinic. So what I do is I put my hand on the patient's shoulder if they don't mind, ask them to focus in the distance, and from a distance here I start to focus and look for the red reflex. Then I come in gently and gradually, with my index finger, I'll adjust, particularly if I know, as Donica does, wear glasses. So as I adjust, I'm trying to look at the back of his eye. Now it's very difficult. People for many years will say, I can't see anything, but what you're looking for in essence are blood vessels in the first instance. So you're looking for blood vessels, and I always describe it like spaghetti going down the sink. And so the blood vessels heading towards the optic nerve. And once you pick on one blood vessel, you follow it along. Don't be distracted. Follow it along towards the optic disc. And that's really what you're looking to see. So you're looking to see the whole disc, of course, but you're heading towards the optic disc itself and the optic nerve head. And you're looking to see, is it like the plug hole of the sink? Is it well demarcated or is it blurry? And you should know quite a number of things about ophthalmoscopy and fundoscopy indeed. So the things you should particularly know about are changes that you see on the fundus of hypertension, and the 4 different stages of it, the changes of diabetes, the changes of papilledema and the causes thereof, and the changes of optic atrophy and the causes thereof. Finally, you should know what causes pigmentation on the retina. For example, Refsum's disease is a rare disease, but also mitochondrial disorders or indeed retinitis pigmentosa. When you're going from the right eye, as I just did, to the left eye, same overall setup, but this time you must move to your left, put the ophthalmoscope in your left hand. So your left index finger is on the dial, and you're coming to the left side of the patient. So you come around to this side, same setup, look into the distance, and you must come in from the left, like this. And I would really urge you not to give up. You need to keep on going because it's quite hard and everyone appreciates that. And don't lie. I mean, I always pretended that I could see things I couldn't see initially because to try and please my professors and things. But to be honest, that's, as I found out in due course, you will get found out. It's a little pointless. The next part of the cranial nerve examination is a combination of the third, fourth and sixth cranial nerves. The third is the oculomotor, the fourth is the trochlear, and the sixth is the abducens. Now they're taken together because they determine eye movements, both pursuit and saccadic eye movements, which sound terribly complicated, but in essence it's how you move your eyes, why you're drawn to certain things, and how you actually attract your eyes to certain things. And the way to understand them, again, goes back to what I said in an earlier part of this video, and that is that the cranial nerve nuclei lie in the brain stem, the midbrain at the top, the pons in the middle, and the medulla. So the midbrain, the middle of the brain, joined by a bridge, pons pontis in Latin, to the medulla, which is the bulb, or the bulbar nuclei are there. So the third and the fourth nuclei are in the midbrain, the fifth runs more or less through the brainstem, sixth and seventh will be in the pons, and more or less, crudely enough, the rest of the cranial nerve nuclei are in the bulb or in the medulla. So midbrain, pons, medulla is the mantra you must understand for the rest of this cranial nerve demonstration. So looking at eye movements, the first thing you must always do when you examine a patient and you're coming towards their eye movements is stand back from it a little, if you like. So Donica, if I could ask you to look straight at the stick here, and I make some general observations. I first of all remind myself, are the pupils equal? Yes. Are the eyes sitting aligned in a normal position? Yes. Is there any evidence of ptosis or drooping of the eyelid? No. And is there any evidence of nystagmus at rest? That, in essence, means jumpiness of the eyes. Is there jumpiness of the eyes at rest? And if it's very subtle, they're called square wave jerks, which are just tiny little bits of nystagmus seen in some cerebellar conditions. So once I've established that everything is fine, the ophthalmologist will talk about doing a cover test if there's seeming inequality. And the cover test is simply to ask the patient to focus on the stick here, and we can see if the alignment of the eyes change when we cover one eye and see if there's any adjustment. Usually this is done, however, in children looking for strabismus or squint. But from the adult neurological perspective, we're looking at eye movements of determined by 3, 4, and 6. Now, there are different ways to do eye movements, and I do them a specific way, and I'll show you why. So if you can look at the stick here, I'm going to ask you to keep your head still if you will, and look to your left. Now you ask a question of yourself, do I see nystagmus? And the answer no. And I ask a question of the patient, and of the patient I say, do you see one or two objects? And in my head now, I'm running through the anatomy of these nerves. So I know that in his left eye, he's using the lateral rectus muscle. It's supplied by the sixth nerve, and the nucleus is in the pons, as I said. In his right eye, he's using the medial rectus muscle. It's supplied by the third nerve, and the nucleus is in the midbrain. Its importance will become apparent in time. So if you're keeping your head still now, I want you to follow this, pursue this, if you will, to the right-hand side. And the same question, do I see nystagmus? No, I do not. Do you see one or two objects? And in his left eye, this time, he's using the medial rectus muscle supplied by the third nerve, the nucleus for which is in the midbrain. And in his right eye, he's using the lateral rectus muscle supplied by the sixth nerve, the nucleus for which is in the pons. Now, most people tend to go into a H-type fashion, but I feel it doesn't lend itself to the understanding of this, so I'm going to be a bit controversial and say, come back into the middle here, turn the stick on its side, and now, keeping your head still, can you look up? Now, the vast majority of pull here in both eyes are the superior recti muscles supplied by the third nerve, the nuclei for which are in the midbrain. And this just keeps it clear as to what you're doing during the examination, as opposed to randomly doing a H and not really understanding it at all. You have to change position for the inferior recti. So I'm going to move the stick down, Donica, but I'm going to put my hand on your face, always ask permission, and I'm going to hold your eyelids gently open. Do not grab the patient by the eyelids straight away. Now, if you're looking straight down there, do you see one or two? One. And these are the main pull is of the inferior recti in both eyes, supplied by the third nerve, the nucleus for which is in the midbrain. Now, for the oblique muscles, you go down into the corners. That's the fourth nerve on the left, fourth nerve on the right, and then the inferior obliques are up, and again, both supplied by the third nerve. So in other words, a little bit of a change to the normal practice. You go, keep the patient's head still, go from left to right to center, up, down, and then go into the corners. It's understanding the eye movements is the most important thing in the first instance before you can then dissect as to what causes dysfunction of these. Now, once you've done the pursuit movements, which I've just done, you then look for saccadic eye movements. Our eye movements should be like the windscreen wipers of a car, and they should be in complete synchronicity. Now, sometimes what happens is, as you imagine when the rain dries up a little bit and it makes that annoying noise on your screen, the eyes can start to jump a little bit, and that's when the saccadic eye movements become out of kilter. And that's very important to test for those. So what you do here is you ask the patient to look to the left, keeping your head still. I want you to look to the right now. To the left, to the right, to the left, to the right, to the left, to the right, to the left, to the right. Great. You can do the same in vertical gaze. Can you look up and down and up and down? But it's usually more productive, if you like, looking on the horizontal gaze, because what you're looking for here is an internuclear ophthalmoplegia. As the name implies, it's ophthalmoplegia or weakness of an eye muscle due to a problem between nuclei. And the nuclei involved are the third and the sixth. So the third nerve nucleus and the sixth nerve nucleus are connected by a bundle of fibers called the medial longitudinal fasciculus. If you have a lesion there, it causes dysfunction of saccadic eye movements that's pathognomonic almost of multiple sclerosis, and that's called an internuclear ophthalmoplegia. And for instance, if, heaven forfend, you had an internuclear ophthalmoplegia, Donica, of your left eye, you'd have of your left MLF, medial longitudinal fasciculus. When I ask you to look to this side, all will be well, but when I ask you to look here, your medial rectus wouldn't work, so you'd have failure of adduction of the left eye, and you'd get nystagmus in abduction of the right eye, because you're always trying to get the image you're looking at on your fovea together. So if you can imagine, you look out here, this one stops moving, and this one goes, where's the image, where's the image? So it's an INO, very suggestive MS, and tested by doing saccadic eye movements. The next cranial nerve is the fifth cranial nerve, or the trigeminal nerve. It has three branches, from above down, the ophthalmic, the maxillary, and the mandibular. The nuclei for the fifth nerve are rather complicated. There are four nuclei which run throughout the brainstem and even dip into the upper cervical cord. Without getting too complicated about it, the essence is that the vast majority are in around the pontine area. Now, you can read up further about the nuances of it, if you like, but I'm going to approach it from a clinical perspective here. So the fifth nerve, as we'll see later with the seventh nerve, has three main components in terms of clinical testing. And they are the motor part, the sensory part, and the reflexive part. The motor part is to muscles of mastication, how you chew. And simply done, you ask the patient to grit their teeth. So can you grit your teeth, please? And you feel the muscle bulk of temporalis and of masseter there. Then you test the pterygoids by asking the patient to gently open their mouth and ask them to push against my hand. Push down and then to one side with your jaw, to me, and then against me. Perfect. So they're the muscles of mastication. The second part is the sensory part, and this clinically tends to come into play a lot more than the motor part in my experience. And the three branches are the ophthalmic, the maxillary, and the mandibular. And it's very important because a lot of people get facial numbness and it's non-specific and you're trying to chase it down. But if you know the anatomy fairly well, you'll be able to discern whether it's congruous with the trigeminal nerve problem or incongruous. The best way to start, as with all sensory exams, is to say, start with soft touch. So every time you do a sensory exam, you must check at the top of the sternum and say, this is soft touch. Once the patient then knows what you're talking about, you can proceed. So I'm going to examine your face by stroking with this cotton wool, and I'm going to ask you to close your eyes. Okay, so if you could close your eyes, I'm going to touch you on your forehead. And I'll ask, can you feel that?
Yep.
And then I'll go to the opposite side. Can you feel that? Does it feel the same on the left as the right?
Yes.
And is there any change as I come across?
No.
Great. Now, sometimes people are a little anxious and they feel they've got numbness on their face and they say, my whole face is numb. And the trigeminal nerve goes back way beyond the hairline. The point is, the posterior part of it is here, right at the vertex. So if someone says, I've got a numbness here, and then you hit the hairline and they say, no, it's normal now, well, then you have to say there may be an underlying anxiety element here. It's only if you go back here and then it becomes normal back here, would you say, yes, there's definitely V1 or the first branch of the trigeminal nerve is involved. The back of the head here is C2, the first cervical sensory dermatome, as there is no C1. So we check the V1 is the ophthalmic branch once more. V2 is down to the cheek. Can you feel that there? And feel that there? And V3 is the mandibular branch, which is down here and down here. They feel the same on both sides?
Yeah.
Similarly with the V3, the posterior limit of it is the angle of the jaw. So you go back here and hopefully it'll become normal again here as we get into cervical dermatomes. So they're the sensory element of it, and you can do it both with soft touch, as I've just done, and with pinprick. You don't do it with vibration sense in this nerve. And the pinprick, again, is checked for the sternum. I use a cocktail stick. And in a similar vein, you say, that's a little sharp there. Don't let me hurt you, I hope. And sharp there. And that feels the same on both sides? Okay, so that's the sensory part. So you've got the motor part for the muscles of mastication and the sensory part. The sensory part usually gets damaged. In young people, we worry about MS, whether there's an MS plaque in the brain stem. Another option is, another common reason for destruction of a fifth nerve is Sjogren's syndrome, which you get dry eyes and dry mouth. And so if you're stuck for causes and it's an isolated fifth nerve, think about Sjogren's. But MS would usually be the first one would worry about. However, in an older population, the commonest time the trigeminal nerve comes into play is neuralgia. What everyone refers to as neuralgia, when the wind changes or when they wash their teeth, they get a sudden sharp, it's called lancinating, which is a stabbing pain down one or two parts of the nerve. The last part of examination of the trigeminal nerve are the reflexes that I mentioned before. Now, this is usually done in the intensive care situation, so you don't particularly need to do it in practice unless someone has, unless there's a very good reason, really. But just to demonstrate how it is done is important. So in a patient who's fully conscious, like Donica, I'd ask him to look up and to the left, high as you can up to the left. Now I'm trying to separate the eyelashes as much as possible. I make, with a clean bit of cotton wool, I make a pointer here, and I'm coming in from the side, not touching eyelashes, and as you'll remember, the sclera is white. So we're not touching the sclera. It's the corneal reflex we're looking for. So I'm going to touch very gently. Sorry, Donica. Sorry. It's not a pleasant thing to do. Very gently over the cornea. And as you saw, sorry again, both eyelids blink. In a Bell's palsy, the efferent branch on the left-hand side is damaged, the seventh nerve. So, for example, if Donica had a left Bell's palsy and I was to do the corneal reflex on the right, what I'd expect is both eyelids to blink normally. If he had a left-sided Bell's palsy, however, the brainstem is alerted to the fact there's something on the cornea, but the right side will blink, but the left side cannot do so because the orbicularis oculus on that side is damaged because of that Bell's palsy. So that really is the fifth cranial nerve, except for in extremis, and the difference between trying to tell the difference between, in extreme situations, trying to tell the difference between a bulbar and a pseudobulbar palsy. One sometimes does the jaw jerk. It's the second reflex attached to the fifth nerve, and it's rather simply done. So I ask the patient to open their mouth fully, and then close it halfway and hold it there. So I put my index finger here. Patients get very frightened about this, so reassure. I'll try and be gentle, and you give a good whack. Okay? Just do it the once or twice. That's normal. The vast majority of times it's normal. Only if you see it being highly exaggerated would I overcall it. I would not call a positive jaw jerk unless it was really obvious and it was in the context of other signs. The presence of a jaw jerk helps distinguish between a pseudobulbar or upper motor neuron lesion of the lower cranial nerves, 9, 10, 11, 12, versus a bulbar palsy or a lower motor neuron lesion of the lower cranial nerves, 9, 10, 11, 12. We'll discuss that later on when we come to those specific nuclei. next cranial nerve is the seventh cranial nerve, or the facial nerve. Its nucleus also lies in the pons. It's innervated from above bilaterally, and it's so-called bilateral supranuclear, above the nucleus innervation. And that has great clinical importance in distinguishing between an upper and a lower motor seventh or facial nerve palsy. The first thing you have to do, of course, is examine it properly. Now, observation in neurology, as I've stressed throughout this demonstration, is key. So when you go along to someone and you say, hello, hi Donegal, nice to meet you, and they shake hands, you're straight away looking at their face, their eyes, and looking around you to see, are there any accoutrements, if you will, that might suggest there may be a stroke, a walking difficulty, etc. So for example, if the person who is right-handed has a speech deficit and is unable to shake your hand, you're straight for the face and you're looking for a right upper motor neuron seventh, and the diagnosis is more or less made there of a left-sided stroke. So the approach to the facial nerve, again like the fifth nerve, involves motor, sensory and reflexive elements. The motor ones are easy enough. Now I find students tend to like to jump in and start touching patients. A little bit odd, but they do. So what I ask them to do is not do so, if at all possible, and clarify the instructions they give. So the first thing I'd ask you to do, Donegal, is raise up your eyebrows as high as you can, as if surprised. Fantastic. Now I want you to frown down as angrily as possible. Wonderful. Now, can you squeeze your eyelids really, really tightly shut? I always say, as if you've got soap in your eyes, so really tight, really tight. Now, I might touch your face at this stage. I'm going to tell you, though, I'm going to try and open your right eyelid, so don't let me. Now, plenty of warning. Patients get frightened fairly easily, so understandably, if someone's coming at them, touching their face, and you can open your eyes. Now, I want you to show me your teeth, right back, if you will. You don't ask them to smile. It's a reflexive thing, so just show me your teeth. That's fine. And can you blow out your cheeks? Fine. So they are the muscles of facial expression. Surprise, frowning, smiling, or mimicking smiling. And they're supplied by the seventh cranial nerve. That's the motor aspect. The sensory aspect is taste to the anterior 2/3 of the tongue. And the posterior 1/3, as we'll see, is via the glossopharyngeal nerve, but taste to the anterior 2/3 of the tongue. Now, first of all, you ask the patient, say, have you noticed any change in your sense of taste? Not in your taste, but in your sense of taste. Okay, I'm going to briefly try and test that at the anterior 2/3 of the tongue, and usually I would use salt and sugar. I won't tell you which, Donegal, but I use salt and sugar, and what I will do is, I'll ask Donegal to open your mouth and stick out your tongue. Stick out your tongue, thanks. And now very gently, I want you to close your eyes. I'm going to put an object on the side of your tongue there. Make sure I don't give you too much. And I want you to tell me what that is. Is it salt or sugar?
Sugar.
Okay, so I don't want to overlabor the point, but in fact you put salt on one end of a spatula, sugar on the other, if you really need to formally test it. Of course, in practice, we rarely, if ever, do. The other question you might ask in the setting of a seventh nerve is about hyperacusis, and that means an increased sensitivity to noise. The reason for this is, in someone with a lower motor neuron seventh nerve palsy, it may affect the nerve to stapedius, which amazingly pulls on the muscle stapedius, which then pulls on the stapes, which is one of the middle ear bones. So if you lose the pull of the stapedius muscle on the inner ear bones, you lose the dampening down effect from the tympanic membrane to the round window, and thus loud noises become particularly severe, hence hyperacusis. You might get a loss of taste, as we've just discussed, and these would normally be in the setting of a lower motor neuron seventh. So, as a clinical key point, you have to distinguish between an upper and a lower motor neuron seventh. The upper is from the cortex to the nuclei in the pons, the lower is from the pons through the cerebellar pontine angle, out via the stylomastoid foramen here, into the parotid, and you'll all remember the 5 branches that come from the parotid of the facial nerve. The easiest way to remember the difference between an upper and a lower motor neuron seventh is what cosmetically you would prefer yourself if you had a seventh nerve palsy. And the answer is an upper, because the upper motor neuron will spare the upper face. Because of what I mentioned earlier, this bilateral supranuclear innervation. What that means is the nuclei are supplied from above the nuclei from both sides. And as a result of that, there's a little bit of compensation for the upper part of the face in an upper motor neuron lesion. However, in a lower motor neuron lesion, particularly a Bell's palsy, or that due to a zoster infection called Ramsay-Hunt syndrome, the whole face is affected. And that looks cosmetically a lot more severe, if you like. In the setting of, as we mentioned with the fifth nerve, in the setting of a Bell's palsy, you lose the corneal reflex response on that side. So in other words, as we showed earlier on, but just to repeat, when you put cotton wool on this eye will blink, but a left Bell's palsy will prevent this eye from blinking, and the eye may become injected and infected, so one should always cover that eye in the acute setting and indeed add eye drops thereafter. So the reflexive part of 7 is the efferent branch of the corneal reflex, which I won't repeat, it was shown on the fifth nerve examination earlier. The eighth cranial nerve is known as the vestibular-cochlear nerve. Vestibulo to do with balance, cochlear to do with hearing. It's rather complex, as you'll recall from your earlier studies, but pretty easy to actually examine in the end. The rhombic sign is positive. It might suggest a vestibular problem. But we also have to look at other aspects of the vestibular-cochlear nerve. Testing hearing is fairly easy, albeit a little crude. So the first thing you do is test overall hearing and ask the patient, well, Donica, do you have any problem with hearing at all?
No.
You don't wear any hearing aids or otherwise? No. And while that may sound very obvious, a lot of people say, oh yeah, by the way, I wear hearing aids. And people take things for granted sometimes. So you must continue to ask the questions, sometimes at the risk of sounding a little foolish. Now, I'm going to mask the air coming in, the sound coming into your left ear by pressing on the tragus here. So I'm pressing on the tragus, and as a gross measure of hearing, I'm going to ask you to repeat some numbers that I'm going to whisper in your right ear, okay? So I'm masking the noise in the left ear. 52.
52.
21.
21.
So grossly, I know that hearing is okay in that right ear. And then I do the same on the other side, masking the tragus on the left-hand side. If there's a doubt about it, then you move on and do the Rinne and Weber tests. These help to distinguish between air conduction and bone conduction. Normally, air conduction is better than bone conduction. In the clinic, it's fairly easy to find a particular tuning fork. For posterior column examination, the tuning fork should be a 128 Hertz tuning fork, the long one if you like. For hearing, however, it's a different frequency, and it should be a 512 tuning fork. So that is, the long one is inappropriate for the hearing test. The Rinne test is done as follows, and it's to distinguish between bone and air conduction. So a gentle tap. A lot of people start hitting themselves rather hard and making a bit of a melodrama of this. So it's a gentle tap to get the vibration going. Don't overplay it. And I'm going to place the base of the tuning fork on your mastoid process here. And can you hear it?
Yeah.
Now, I hold it there. This is bone conduction I'm testing until it dissipates to the point that you can't hear it. So if you could tell me when it stops.
I can't hear it now.
And then I bring it over his ear. Can you hear it now?
Yeah.
So now I know that air conduction is better than bone conduction. And thus, all is right with the world. The other test you can do if you're unclear is Weber test. You really don't need to proceed thereafter, but you can go on to the Weber test by placing the tuning fork in the middle of the forehead, pressing rather firmly, and seeing if it localizes or lateralizes to the right ear, to the left ear, or it's more or less the same. I usually just ask, is that any different in one ear or the other, or is it the same? Okay, thanks. That's fine. The ninth and 10th nerves are done together. They're the glossopharyngeal and vagus nerves. Now, there's not an awful lot you can do by the bedside, but you do need to check some important points. The biggest problem that we worry about in clinical practice is whether a patient can swallow safely or not, and this is important. So when you come to a patient and see they've got a nasogastric tube or a PEG tube in, clearly there's a problem with swallow in most instances, now, in the neurological world. So what we do for the 9 and 10, we take them together and we ask the patient to open their mouth as wide as they can and just tilt their head back a fraction, and you shine a torch in to look at the palatal movements, or palatal, and you ask the patient to say a big ah, and again, and you're looking for the movement, upward movement of the uvula and the symmetry of the upward movement of the palatal folds, which are obviously normal here. And if a patient says, I've had the odd choking episode, I'm not feeling great, or they've lost weight, you must test the gag response. And that again involves asking the patient to open their mouth wide. taking the tongue depressor and putting it right in. I'm not going to hurt Donica, but in essence, what people tend to shy away from is being as necessarily as aggressive as you have to be, which is going right back to the posterior pharyngeal wall to establish whether or not the gag is present or not. If you don't do that, the gag hasn't been done properly, in which case you can't make any good clinical decisions. The 11th cranial nerve is the spinal accessory nerve. So there are two parts to it, but in essence, in terms of testing, it's testing the muscles around the neck. It tests the sternocleidomastoid muscles, and it tests the trapezii. Now, to do this, like all muscles, the first thing you must do is look at them. You must see if there's any wasting, you must see if there are fasciculations, and then test the power. And once you keep doing things methodically, it becomes second nature, really. So I'll have to look at the muscles first. So if you don't mind, Annika, would you mind just exposing take it off the top and looking at the trapezii, the shoulder muscles? That's fine. So I step back a little bit and look for symmetry. And I can't see any evidence of wasting. A little bit more closely, I might look for fasciculations or jumpiness of the muscle, and there aren't any. So once I've established that, I'll ask him to shrug up your shoulders, please, and that's symmetrical. Now I'm going to test the power. So I'm going to push up against me and don't let me hurt you. Push up, and that's fine. So it's grade 5/5 power there. The other muscles you test are as I said, the sternocleidomastoid muscle. Now, to test the left sternocleidomastoid muscle, the patient turns their head to the right, away from the lesion. And you can see it fairly clearly, it'll come through here. So if you turn it towards the wall there, if you don't mind, all the way over. Perfect. Now hold it there, and I want you to push against my hand. Push hard. And you can see the sternocleidomastoid muscle there perfectly. And if you turn away from me, all the way, and push against my hand, sternocleidomastoid muscle, and no loss. I would recommend at this stage also that you would test neck muscles, particularly in conditions such as motor neuron disease and myasthenia gravis. And the neck flexors tend to get affected quite early. So if you could put your chin onto your chest, I'm going to put my hand on your forehead. Don't let me hurt you, but push against my hand as hard as you can. A bit like a headbutt. Hard. Okay, so always check those just while you're in the vicinity. And that really is all there is to the spinal accessory nerve. The 12th cranial nerve is the hypoglossal nerve. Its nucleus, as we stated in earlier parts of this demonstration, is in the medulla, or bulb of the brain stem. It is the nerve supply to the tongue. So it's straightforward enough, but so long as you remember, as I've said on a number of occasions, that the tongue is a muscle. Therefore, it must be observed at rest. You must look for wasting, fasciculations, look at its movement, and even indeed test its power. So, if I could ask you to open the mouth wide, please, Donica, and you look at it at rest in the first instance. And what I'm looking for here are jumpiness or fasciculations of the tongue. And sometimes it's hard to tell, but don't overcall it, is what I would advise. So in other words, if you see fasciculations, excellent, they're there, and if you don't overcall it. Don't be in too much doubt. If then you see it's wasted, you say, oh, it's wasted on one side of the tongue or the other. And then you ask the patient then to say, can you stick out your tongue straight, please? And if the tongue deviates to one side or the other, you must step back a fraction just to say, does the tongue deviate or not? And back in, thanks. If, for example, Donica sticks out his tongue and the tongue deviates to the right-hand side, the 12th nerves come from the hypoglossal foramina and supply both sides of the tongue. So if Donica had damaged for some reason his right 12th nerve at nuclear level, at foraminal level or elsewhere, then the nerve supply into the right side of his tongue is lost, of course. So when he goes to stick out his tongue, the tongue will deviate to the side of the lesion because it's pushed over by the functioning left-hand side. Now, the other thing you can test is coordination. So dysarthria, as you'll find out later, is a difficulty with articulation, which may be due to cerebellar disorders and other disorders, but it can be simply due to something wrong with your lips or with your palate or with your tongue. So you ask people to go la, 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 like that. So side to side, if you could move your tongue to look at coordination. Side to side, quick as you can. Yeah, thanks very much. They don't feel great about it, but at the same token, it does help to see the rapidity of movement, which can be altered in cerebellar disorders in particular. And then finally, if you want to just test one more thing, you can test strength. Don't usually do it, but you ask them to put their tongue into their cheek and push against my hand, and then on the other side. Not absolutely necessary, but just to finish it off and make sure you've covered all angles before you say that you've finished the examination of the 12th nerve.